percent of the volume we implant. So we try to overcorrect if we need to reach symmetry with the contralateral side.
Any further questions? It seems to be already a well-accepted method. So, thank you very much, Fabio.
Thank you.
I would just like to, at the end of this kind of session, to thank the organizing committees of the association and the research council, because I think this is a very, very good chance to improve the exchange of knowledge between basic scientists and clinicians, and speed it up, that it has its implication to our clinical work on one hand, and on the other hand, that it's really deepening the relationship between the European Association and the American Association, and I hope that this we can continue intensively. Thank you very much.
Just hit that guy. I can just do this kind of thing. Good. Perfect. All right, good. This guy. 4. Got Good morning. My name is Ken Shestak, and I have a distinct honor to introduce Dr. Michael Bentz, the 2016 President of the American Association of Plastic Surgeons. I've known Mike for about 25 years, and including 10 of those years while he was in Pittsburgh, initially as a resident and then as a co-faculty person. And I think pretty much everyone in this room is familiar with Mike and realizes that he's a person who has an array of outstanding qualities. He is first and foremost, in my mind, someone of tremendous integrity. It's really pervasive in everything he does, and it's an essential aspect of his life. This is followed closely by what I perceive to be an unparalleled organizational ability. Dr. Bentz is someone who has a plan for the important goals in his life. And by virtue of his organized thought patterns and his incredible attention to detail, he's able to move from task to task to achieve goals while not missing the human dimension around him. Just a little anecdote, while he was at Pitt, Mike would carry with him a little black date book that he would write details into from day to day, patients, this and that. It kept him and the people around him quintessentially organized. In thinking about it, I'm pretty sure there was not another book in the whole Department of Surgery with that amount of important information. I've also always felt that Dr. Bentz is really a gifted educator, and he has a passion for teaching. He's also an excellent surgeon in many aspects of both adult and pediatric plastic surgery. I think it's important for all of us to realize he's, in every sense of the word, a people person. He's also somebody who is absolutely dependable. I don't know that I've met too many people in life I can say that about. But I can recollect from my experiences with Mike and his reputation at Children's Hospital, everybody knew he was totally dependable from the CEO all the way on down. And he sort of became the go-to person at Children's Hospital in Pittsburgh for problems. You know, sometimes with parking, sometimes with patients. I'm sure there were times when there were difficulties with families of patients who were not on plastic surgery, and somehow Mike got involved and was able to offer a solution. I think that was sort of a testament to the level of his capability and the trust that he had in Children's Hospital, which was, I think, kind of amazing. And I'm pretty sure, given the fact that he's the Vice Chair of Clinical Affairs at the University of Wisconsin, the same has been true at Wisconsin. Dr. Bentz is a leader, and he leads by example. He doesn't ask people to do things that he won't do. And his example is an example of great consistency. And finally, I think it's important to emphasize that behind all of this is a sensitive, caring individual who is simply a great human being. Mentorship has been a hallmark of his career, and Mike will be the first person to tell you that he's been strongly influenced by his mentors along the way, first in his general surgery training by Wally Ritchie, the chair at Temple University, and then clearly by Bing Rickers, his colleague, friend, and surgical chair at the University of Wisconsin. His plastic surgery mentors have included Bill Futrell, a former president of the association, Fred Heckler, Peter Johnson, and the late Ross Musgrave at the University of Pittsburgh. Upon arrival in Wisconsin, Dave DeBell and Mike developed a relationship that I think was very helpful to him. And Dr. Bentz is especially indebted to Barry Noon, who he credits with having taught him a great deal about executive leadership in organized plastic surgery. Mike, in turn, has been a great mentor for members of not only his faculty, but the residents at the University of Wisconsin. So in the late 90s, Dr. Bentz was heavily recruited by Bing Rickers to Wisconsin to become chief in the division of plastic surgery. He was tasked with building upon the tradition put in place by Dave DeBell. Mike set to work immediately on revitalizing the program, and in relatively short order, he also became a vice chair in the Department of Surgery, received numerous accolades for leadership contributions at the University of Wisconsin, and was quickly recognized as a leader in national organized plastic surgery. Over the course of his early career at Wisconsin, he and Dr. Rickers became very close friends, established a great working relationship, and Mike frequently talks about that as a highlight of his career in Wisconsin. Mike now occupies the Leighton Rickers MD chair of surgical leadership. During the past 17 years, Mike has fulfilled his primary mission, building a truly great plastic surgery residency training program at the University of Wisconsin. During the past 2 decades, Dr. Bentz has gained national recognition for expertise in many areas of plastic surgery, but most specifically, pediatric plastic surgery, where he's the primary editor of 3 seminal textbooks. He also has tremendous knowledge and expertise in the area of congenital hand surgery, and has become an expert in the treatment of head, face, and neck defects following Mohs surgery. He's presented numerous instructional courses on these and other topics at national meetings. Dr. Bentz's legacy in plastic surgery is clearly centered around teaching, service, and leadership, but there has been considerable scholarship also during his time in Wisconsin. In addition to plastic surgery resident education, Mike has been instrumental in organizing and leading outreach missions in plastic surgery, initially working with Interplast and most recently establishing a permanent presence in Nicaragua for the University of Wisconsin residents and faculty. He's assembled a most distinguished service profile in plastic surgery with numerous leadership positions in both regional and national plastic surgery societies listed here. This has culminated in his serving as chairman of the American Board of Plastic Surgery in 2013 and president of this association during the past year. There is much more to Mike Bentz, though, than medicine and plastic surgery, however. He has been married for almost 28 years to an equally fantastic person, his wife, Kim. They met during his residency at Temple, were married in Philadelphia, and lived there until their time in Pittsburgh, where they stayed for a little more than 10 years. The last 17 years have been spent in Wisconsin, and I think they would both tell you it's been a great ride, and more importantly, they've done it together. Family and spending time with their kids, when you talk to them, it really comes through a lot. And it's been a particular joy, I think, for both Mike and for Kim. They've had great pleasure in watching their daughter Gretchen and sons Alex and Eric mature into fine young adults. They still love to do things as a family, especially boating and water skiing on the Great Lakes, the fantastic lakes. There's no Great Lakes, fantastic lake in Madison. And so it's my pleasure to present Dr. Michael Bentz, who I consider to be about the best person I've ever met in plastic surgery and in medicine, this year's association's president, for his talk entitled, "The Plastic Surgeon at Work and Play." Dr. Bentz.
I think we should just go to the coffee break. I can't live up to that. Ken, thank you for that too generous introduction, for your mentorship, and most importantly, for your friendship for over 25 years. Members of the association and research council, friends, colleagues, and guests, thank you for the honor of serving as your president this past year. The American Association of Plastic Surgeons represents the very best in plastic surgery, with members who are highly accomplished in organizational impact that continues to grow both nationally and internationally. I encourage you to share your talents and passions and become involved in our many traditional activities and new initiatives that the association is engaged in. Our success depends upon your involvement. I do want to take a moment to offer my appreciation and admiration I need my slides, please. Offer my admiration and to each of the officers, board, committee chairs, and committee members of the association who give so much to our organization, particularly Jim Zins and Mary McGrath, our future leaders. The association is in great hands. As you know, it's a year of change. Your board even went bowling one night. I also thank my mentors and partners from my time as resident, fellow, and attending at the University of Pittsburgh, particularly Bill Futrell and Ken Shustak. I offer my thanks and affection to my faculty colleagues at the University of Wisconsin who have supported me, covered for me, cleaned up after me, and provided 17 years of fun in Madison, including John Siebert, Venkat Rao, Sam Poor, and Neil Salyapong, who are with us this morning, and Dave DeBell, John Doyle, Brad Manning, Del Mount, and Ahmed Afifi, who are back taking care of the home front. I would not be up here, though, without the daily support and stimulation of our superb Wisconsin residents, my other partners. Finally, my love to my daughter Gretchen, our world champion equestrian and epic project manager, son Alex, our expert fisherman and environmentalist, and son Eric, our fearless competitive skier and undergrad, and finally Kim, the love of my life. They and you are actually the reason that I have chosen my topics for discussion together this morning. As a formality, I have no relevant disclosures to report, but I do hope to have some one day. For those of you who have been fortunate to experience association presidential addresses over the years, you've been treated to diverse stories of history, plastic surgery accomplishments and innovations, ghosts of the past, philosophy, exploration, and global engagement. The majority of the time, when any of us gives a talk, it is usually about someone else, most commonly our patients. This morning, I have chosen to talk about you, about me, about our families, and about us. As I stand here, I see an incredible group of clinicians, educators, scientists, surgeons, and loved ones. You are the most important assets to the future of plastic surgery. My question for all of us this morning is, how are we doing in protecting plastic surgery's most important assets? How are we doing protecting you and me? My goal this morning is to stimulate additional conversation about three interrelated topics of physician wellness. One is surgeon health. The second is the stress of surgical practice, inclusive of the implications of burnout. And the third is the eternal challenge of work-life balance. My second disclosure of the morning is that I don't consider myself an expert at any of these topics. And in fact, I am only intermittently successful at them, as my family will tell you. But I am getting better. I have a few personal experiences that I will share that have led me to become progressively interested in each of these three topics. They're definitely related. I hope you will become more interested too, as your personal outcome at home and work is fully dependent on how you manage them. It's not clear to me that collectively we take them seriously enough. My first eye-opening introduction to surgeon health and surgical practice outcomes occurred when I was reviewing a survey of University of Wisconsin Department of Surgery residency graduates. One of our general surgery attendings, Bruce Harms, reported in Annals of Surgery that 32% of our UW graduates developed major health issues during their practice lives, with 50% identifying health compromise after the age of 50. 20% of which led to an early involuntary or voluntary retirement. 1 in 5. If you look 2 people to your right and 2 people to your left, that means one of you leaving your practice earlier than you would have otherwise selected. In addition, 8% of our graduates self-identified as being alcohol dependent. Now, when you see data like this presented from other places or institutions, it's pretty easy to write off as being different than your local environment, perhaps not even being applicable. But this data reflected our department's graduates across multiple specialties, our UW family. The reality is that my work family and your work family are more similar than different. These types of discouraging practice outcomes straddle all 3 areas of discussion this morning and should raise concern at an individual and collective organizational level, including within our leadership organizations. The first topic of the 3, plastic surgeon health, is actually the simplest one to conceptualize and talk about. It is the one that is most easily compromised in our complicated, hectic, and overscheduled lives. 7 years ago, as many of you know, I developed a subclavian venous thrombosis due to thoracic outlet syndrome in my right dominant arm. When I first looked at my Popeye arm, it looked kind of cool, till I looked at my wimpy, normal left arm and realized I had a problem. After a few days of TPA and heparin, my follow-up venogram revealed a stenosis that required a first rib resection. I did well through that and returned to the office 6 days later. That was ridiculous, causing a 3-unit hematoma, a readmission. Not so smart on my part. While there were a few moments of early levity during the initial hospitalization, including a faux headline in The Onion about me having a rib removed and not looking any thinner, the laughs turned into more duress for me as my new PCP worked me up over 330 days for other thrombotic etiologies, including an array of abnormal lab tests and procedures with false positives and false negatives that required additional testing. Did I have a problem from the many, many unreported needle sticks and splash exposures I had sustained? Was an occult cancer making me thrombogenic? How would I have known? I never went to see my PCP, had no age-relevant screening, and never reported any type of exposure. While it turns out I am fully healthy, I had not taken the responsibility up to that time for my own health, impacting not only me, but also my partners, our residents, and my family. Having had the first-hand opportunity to learn more in depth about surgeon health because of this, there's actually data to suggest that regular PCP visits will optimize your health. Shanafelt showed that surgeons who had seen their primary care provider within 12 months were more likely to have up-to-date, age-appropriate healthcare screening and had superior physical and overall quality of life scores. That latter fact will become more important in a couple minutes. As an aside, and while we're on the subject, there's also data that suggests that no matter how good a physician that you are, you should probably not be caring for yourself or your family members as an alternative to having a PCP. In a survey of practicing physicians, 33% organized their personal medical care through quarter consultations, while 46% acknowledged treating themselves and their family members. You know the drill. We've all done it. you figure out what you or your family member has, frequently without lab work or imaging. You grab your favorite consultant in the hallway, tell them what you think. They tell you how to manage it, and they don't get the lab work or the imaging either, so it's totally contingent upon your degree of objectivity. In a survey of those that did treat their family members, 50% felt that their family ultimately received equivalent care of their patients, only 12% received better care, and 31% received worse care. In some contrast, but as a reflection of our plastic surgery psyche, a survey of ASAP's members, analyzed by Slavin and colleagues, showed that 88% of 465 respondents would consider operating on a family member, while 84% said they had. Of those that had, 67% of the surgeons self-reported that they were the best surgeon for the procedure, leading to an outcome of 99% patient satisfaction of their family. With a 99% patient family satisfaction rate, I wish my family was larger. Bottom line, we should not neglect our personal health. The second component of the talk, the relationship between practice stress, surgeon burnout, and patient care outcomes, is more interesting, but also more difficult. One of my responsibilities as clinical vice chair of our Department of Surgery is to work with surgeons who receive poor patient satisfaction scores, generate patient and/or staff complaints, and a few who can occasionally be disruptive. My responsibility is to identify the struggling surgeon as early as possible on the front end and work with them to avoid downstream repercussions and additional challenges. I failed miserably at this several years ago and have not done that part of my job quite the same way since. One of our subspecialty surgeons, thankfully not a plastic surgeon, but known to be highly functioning in the OR, albeit highly demanding of staff and people around him, went home one evening, shot his wife, and then shot himself. She survived. He did not. Unfortunately, I never saw it coming. None of us did, even after doing repeated reviews of what we could have seen or should have done. There were minimal, significant indicators to forewarn what was to happen. In retrospect, there were some subtle signs of burnout, personal and professional stress, but not a hint predicting the magnitude of the final act, a thankfully infrequent response to burnout in surgeons. Physician burnout is a topic gaining more and more attention, both in the lay literature and the scientific literature. A September 7, 2015 Time magazine article entitled "Life Support Inside the Movement to Save the Mental Health of America's Doctors" described a growing recognition about the significance of physician burnout. Plastic surgery has also begun to recognize this problem, including a relatively recent ASPS survey, several peer-reviewed manuscripts, a thorough plastic surgery news article just a few months ago in March, the ACAPS panel planned for tomorrow that I encourage you to attend, and upcoming programming at ASPS in Los Angeles. Everyone here this morning, everyone in this room, will recognize that our practice lives are stressful and progressively more complicated due to multiple factors: increasing regulation and bureaucracy, verbal order audits, medical record audits, coding audits, business audits, practice audits, a growing clinical production emphasis, medical legal threats, and loss of autonomy. We work to push our advanced practice practitioners to work at the high level of their license, and yet we do things that are probably not very efficient use of our time. That aside, the fundamental fact is that patient outcomes can be compromised by surgeon burnout, while at the same time your personal outcome can be similarly compromised. The Time article reinforced to the public that physicians practicing while suffering signs and symptoms of burnout make more medical errors, deliver diminished quality of practice, and exhibit decreased professionalism. Burnout, interestingly, also leads to patients who are less compliant with recommended care plans. Drilling down and looking specifically at 1,700 ASPS members in the 2011 survey, Rolani and colleagues reported a validated plastic surgery burnout rate of nearly 30%, with 1/4 of ASPS plastic surgeons, 1/4 of us, having a quality of life norm less than that of the general population. Identified risk factors included subspecialty practice, hours worked, nights covered on call, annual income, practice setting, and academic rank. There were also more homework conflicts and a nearly twofold increased risk of self-reported errors and impairment. These data are ours, yours and mine. Balch, analyzing a broader American College of Surgeons survey, noted that academic surgeons were less likely to experience burnout than surgeons in private practice, less likely to screen positively for depression, and more likely to experience career satisfaction and recommend a surgical career to their children. In that survey, burnout was associated with trauma surgery care, nights on call, and number of hours worked. In a private practice setting, burnout was most associated with the practice that involved 0.3 to 0.5 FTE of effort in non-clinical activities, incentive-based pay, nights on call, and also hours worked. In this study, plastic surgeons fell in the middle of the pack relative to our fellow surgical colleagues' responses, with 37% of us exhibiting signs of burnout, 1 in 3 of us sitting here this morning. Look one person to your left and one person to your right. It's probably the other guy or lady. We were near the top of all ACS member surgeons at 31% of us possibly not choosing to be a plastic surgeon again. 31% of us possibly choosing not to be a plastic surgeon again. Looking specifically at academic surgeons and their work environment, Way and colleagues identified the strongest predictors of overall satisfaction as it relates to their home departments, which included shared department governance, collegiality and collaboration in their departments, and the nature of their relationship with their supervisor. SOAR, writing in surgery, reinforced the direct relationship of job satisfaction and burnout with the employer's level of organizational productivity, efficiency, and creativity. Looking specifically at chairs of surgery in an effort to understand the impact of the leadership environment, 11% expressed dissatisfaction with their work, with younger chair age and fewer years as chair associated with higher job satisfaction, as was adequate clerical support and the opportunity for innovation. Next week, go back and let your administrator know how much you appreciate them. As you might anticipate, there is a career stage component associated with these issues. Derby studied early, mid, and late career physicians, defining stages as either less than 10 years in practice, 11 to 20 years in practice, and more than 21 years in practice. Early career physicians had the lowest satisfaction of career choice, the highest frequency of work-home conflicts, and the highest rates of depersonalization. Middle career physicians worked more hours, took more call, had the lowest work-life balance, and highest rates of emotional exhaustion and burnout. Middle career physicians were the ones most likely to leave the practice of medicine for reasons other than retirement. Later career physicians had the highest career satisfaction, highest work-life balance satisfaction, higher likelihood of reducing work hours voluntarily. This study, however, did not address two significant current discussions in healthcare. One is the impact of burnout and its association and repercussions on our residents and their families. And on the other end of the spectrum, the evolving and important conversation about when one should retire from the clinical practice of surgery as impacts future workforce analyses and decisions. Evidence of the relevance of the retirement topic to this association audience was the attendance at one of our previous early mornings masterclass sessions addressing it. The room was overflowing to the point it looked more like the cosmetic A session at the ASPS. In reference to later career surgeons, Rourke, McGrath, Lawrence, and colleagues identified factors that affect a plastic surgeon's retirement plans. The top 5 of these include rising malpractice costs, insufficient reimbursement, practice stress, increasing regulation, and on-call responsibilities. Luce's 2011 PRS article, The Aging Surgeon, defines our practice demographics as well as the complicated relationship between performance and experience. Luce points out that medicine in general, and surgery in particular, lacks a tool to define when technical and cognitive functional change precludes the safe practice of plastic surgery. There are inherent risks to letting us individually define that for ourselves, and thus the imperative of a broader, thoughtful conversation that leads to the optimal extension of a safe practice life for both patient and plastic surgeon. This concern has also been articulated by the American College of Surgeons Board of Governors Physician Competency and Health Work Group. They note that surgeons may not recognize their own cognitive or technical skill loss, and that colleagues and coworkers may need to identify colleagues who exhibit warning signs of professional deterioration. This represents an additional potentially significant stressor for both surgeon and colleague, but one that may be unavoidable in the absence of validated formal professional practice metrics. We as plastic surgeons need to take the lead in figuring this out before an external agency does it for us. On the other end of the spectrum, and the central focus of a shifting training paradigm, are our resident colleagues, no less than the future of plastic surgery. Practice-based stress and burnout is not limited to attending surgeons. Chepou and colleagues in France found that 25% of plastic surgery residents had high depersonalization scores, 14% reported high levels of emotional exhaustion and burnout scales, and 48% had perceived low levels of accomplishment. Interestingly, weekly ward rounds with a senior surgeon was identified as being protective against resident burnout due to helping limiting depersonalization and facilitating the promotion of personal accomplishment. When I read this paper, I have to admit I was surprised by the data. As faculty, you and I commonly transmit the challenges and difficulties of day-to-day practice to our residents, and less commonly the privileges and joys that also occur daily. When we find ourselves asking why more of our residents do not go into academic plastic surgery, this may be at least one partial explanation. One obvious and intuitive solution to resident burnout would seem to have been the limitation of resident work hours. A review of 27 separate studies by Bolster in the Journal of Graduate Medical Education concluded that focusing on duty hours alone has not resulted in improvements in patient care or resident well-being, and has had an unintended negative impact on resident education. Just recently, the initial analysis of the ACS FIRST trial, published in the New England Journal of Medicine, showed that residents in a flexible duty hour work group did not work more hours than the standard group. Rather, they worked more effectively by rearranging their hours. There was also no reported difference in resident satisfaction regarding education or overall well-being, in spite of a higher reported impact on personal activities. Separately, night float, in contrast to traditional call, has been noted to decrease sleep and increase fatigue and stress. These types of data should stimulate a reconsideration of our approach to rotation scheduling and call coverage. While my focus so far has been about the attending and resident surgeon, if you are fortunate enough to be sitting next to your spouse, partner, or loved one this morning, recognize that they are impacted too. Just ask them. Sargent and colleagues showed that orthopedic residents with a supportive spouse showed lower levels of burnout. Resident spouses themselves reported an 18% incidence of psychological distress, in contrast to only 10% of faculty spouses. They also reported greater loneliness and stress. While marital satisfaction was still reported as high, decreased satisfaction correlated particularly with excessive surgeon irritability and fatigue that precluded involvement in family activities. Somehow, we need to do better for our residents, our families, and ourselves. The third and final piece of the puzzle this morning, and one that is a bit more elusive, is the concept of work-home or work-life balance. Physicians in particular have a well-documented and well-studied propensity towards dissatisfaction with work-life balance as well as burnout when we are compared with the general population of working adults adjusted for age, relationship status, gender, and hours worked per week. This includes others with advanced doctoral degrees. Shanafelt in Archives of Surgery studied 7,200 surgeons, 52% of whom had had a work-home conflict in the 3 weeks preceding the survey. Hours worked per week, having children, gender, VA employment, and academic employment were independently associated with increased risk of homework conflicts, while increased surgeon age and some subspecialty practices were associated with decreased risk. Surgeons with a recent homework conflict were more likely to exhibit symptoms of burnout, depression, and alcohol abuse. I received my first personal lesson about homework balance from my then 4-year-old daughter Gretchen when coming home late one Friday night after operating all day. She met me coming up the stairs from our garage with her hand on her hip, casually asking me if I was going to be a doctor or a dad that weekend. I suspect she did not, she's down here laughing, it wasn't funny at the time, and it was like this. I suspect she did not quite mean it the way I took it, and I'm pretty confident Kim didn't put her up to it. But as a simple and direct question from a child, it was that much more painful. It was also a wake-up call that I was smart enough to appreciate. While many of us struggle with this balance, I had no idea how much reaction I could stimulate by talking briefly about it. At the 2014 association meeting in Miami, an ACAP-sponsored panel addressed balance in our professional lives: clinical care, research, education, leadership, and home, in that order. My 8-minute talk, entitled Work-Life Balance, the Holy Grail of Surgery, generated more conversation during the following break, and later by text, email, and phone call, than any talk I have given anywhere of any length. On one hand, there was significant feedback that we did need to talk about it and more publicly. On the other hand, several colleagues expressed concern that I was sending the wrong message to our more junior colleagues who might somehow misinterpret my message and get the impression that there is a shortcut to excellence. Categorically, there is no shortcut to excellence, whether you believe or not in Erickson and Gladwell's 10,000 hours. We can, however, be effective, successful, and engaged at home while simultaneously contributing professionally and being academically productive. In fact, I believe we're better at work when we're better at home. The key is to define it for yourself, honestly assess your success, then redefine it and reassess it over time. At the risk of a perhaps uncomfortable response, or hopefully not, ask the people around you how you're doing. I have. A little painful at times, but helpful. But it will be the information you need to improve and move forward. The victims of my personal learning curve, seated down here in the front row, have somehow so far survived my well-intentioned work-life imbalances. Know that we never permanently arrive at the optimal home-life balance. It's a perpetual journey in search of the proverbial holy grail of surgery that will require you to be strategic about your time. At certain points in your career, saying yes to something means you will need to say no to something else. In the spirit of Indiana Jones and the Last Crusade, choose wisely. There is hope. Shanafelt defined general strategies for success towards improving the quality of life of surgeons. These include finding meaning in your work, focusing on what is important in your life, maintaining a positive outlook, embracing a philosophy that stresses work-life balance, and employing a broader repertoire of wellness promotion practices. These somewhat generic recommendations, while directed at surgeons in practice based on an American College of Surgeons survey data set, can, I believe, be extrapolated to our resident colleagues. Verheiden and McGrath looked at social problems in plastic surgery residents as impacts their training. One does not need to dig too deeply into their PRS article to appreciate that some of these problems may be either the cause or result of homework balance issues at the resident level. Additionally, it is easy to further appreciate some contributing weaknesses in our traditional approach to residency training and to understand the impact of one such stressed resident on his or her residency program. Most of us have likely already experienced this unfortunate phenomenon in one way or the other as a residency director, faculty member, mentor, institutional leader, or even as co-resident. Thankfully, there are practical solutions that can be implemented towards improving work-life balance at the attending and resident level. Some need to occur at home, some need to occur at work, and some, importantly, between the two. Integration of work activities and people, including family and domestic and international business travel, tacking social travel onto business travel, carved out days at home with nothing to do, work-related social functions that involve family members, and planned group athletic activities are just a few. Global health participation of a surgeon and a family member is a unique opportunity to not only revisit your motivation to enter medicine, but to also share what you do on the most intimate level with a child or loved one. Group athletic activities are useful outlets that have been studied. Our division, for example, runs an 8K benefit race together each spring with 18,000 of our best friends, not only as a team-building exercise, but also as an additional motivation to stay in shape during our balmy Madison winter. This team athletic approach has been formally described and studied in a Mayo Clinic program where incentivized exercise participants reported statistically higher quality of life scores, higher compliance with HHS and CDC exercise recommendations, and a trend towards lower symptoms of burnout. Stanford University, in response to the tragic suicide of a general surgery resident, initiated a Balance in Life program, establishing senior resident, junior resident mentor pairings, provision of resources for stress relief and emotional support, and facilitation of organized social programs. At the home front, event prioritizing and early academic calendar scheduling of key family events is crucial, particularly given the current administrative consequences of late OR and late clinic cancellations at each of our institutions. Better and frequent communication via cell phone, but also by text, FaceTime, Skype, Snapchat, Instagram, Facebook, and others is essential and fun, particularly with our children. It took me a little while to figure out that my kids might not answer my cell call, but they would respond to a text in nanoseconds. Additionally, the orthopedic study by Sargent looked at surgical spouses and significant others, showed that full-time spouse work outside the home, a gratifying sex life, which I'm not going to address this morning, and 90 minutes spent together daily correlated significantly with marital satisfaction. As you can imagine, there's more data like that which I presented this morning to help us begin to address these topics formally and comprehensively. Where we do not have the data, we should acquire it. Protecting the future of plastic surgery while optimizing your and your family's future is a worthy task for us all. In closing, take your personal inventory and ask these 4 questions. Are you at risk for health, home, and burnout challenges related to being a plastic surgeon? I believe the answer is definitely yes for all of us. Number 2, can you improve your general well-being, physical health, and home-work balance? I believe the answer is very likely yes for most of it, and it's definitely yes for me. 3, can that personal involvement and improvement lead to improvement in your patient care and performance at work? I believe the data suggests that it will. And finally, will the future of plastic surgery be secure by us all doing so? As you are the future of plastic surgery, whether an association member, research council member, guest, resident, student, I am confident the answer is yes, it will be. It's an incredible privilege to be a plastic surgeon. We are fortunate to intimately share the lives of our patients and have daily meaningful impact on them. We take exceptional care of our patients, our laboratories, our residents, our students. Let's also pledge to begin the journey to take better care of ourselves, better care of our families, and better care of each other. You're likely familiar with the old Chinese proverb that the journey of 1,000 miles begins with a single step. Let's take that step together. I thank you again for the honor and privilege of serving as your president for this distinguished organization during the last year. And in somewhat a-traditional fashion, I'd like to open up this address for discussion in the couple minutes we have left. Thank you. No data, no statistics, but I'd be interested in your thoughts.
So, Mike,
Jim Zins.
that was magnificent. One question. Have you been able to, how do you, or have you been able to say no in your professional experience with regard to committees and other responsibilities?
So I have. Probably not as often as I should have. It's a combination of both trying to give back to plastic surgery, participate, and yet assure that balance of taking care of family, friends, and primary responsibilities. It's a moving target. And the first time you say no, I think is the hardest. Not that it gets a lot easier, but I think as you begin to try to achieve the balance of that, it does get easier if you focus on the things that are important. Jim.
Mike, that was spectacular, and I really appreciate the effort that you put into that. I thought it might be helpful to tell a little anecdote from my own professional life from about 25 years ago. I was sitting with our chairman of surgery, and the chairman of surgery at UAB at that time had a bit of an estranged relationship with his son, who was 22 years old. He went up to Alaska, got a job on a fishing boat, got entangled in the nets, and thrown overboard, lost at sea. And, the chairman of surgery, obviously, great remorse for the relationship that he had with this child. And what he told me at that time was, he said, we're very, very good as surgeons at scheduling our time. We schedule our patients, our appointments, our surgeries, and what is left over is what we leave for our families. So he said, take the time to schedule time with your family just the way you do everything else. And I've never forgotten that.
Thank you.
Hey, Mike, that was very impactful personally. Thank you very much, and I'm sure it'll have an impact on many people in the room. What do you think about the role of a third party, if you will, coach in this process, someone like a life coach or perhaps chairman as coach for their junior faculty?
I think we're all fortunate to be surrounded by tremendous mentors, whether that's someone who's professionally trained in that role or someone who has mastered some of these skills. I think to have an outside perspective, it's sometimes difficult to see the forest when you're in the trees. So I think asking for help from those around you in perspective is critical to being successful at this. Thank you. Dick Dabb, the first plastic surgeon I ever saw operate.
Well, that's what I was going
Thank you.
to say, because I can't tell you how proud I am to have been part of your career. And
Thank you.
I'll just always admire what I see, how you've bettered yourself so far beyond what I've ever done in my career. I'm about to end my career. I don't know when. I'm 72, and I still haven't figured out when I'm going to quit or retire. And I've been part of this mentorship program this year. And I would challenge the association to help us fossils. I'm not in I have a clinical appointment at Hershey and Hopkins, but I haven't had the joy of being truly part of a university environment. So there are a lot of us out there that don't quite know what to do to keep from going brain dead after we stop our clinical practice. Maybe we do, maybe we don't. But I think it could be an interesting challenge to try to figure out how to utilize members of the association and plastic surgeons who are leaving their practices to do the kind of things you're talking about, because I really see a lot of the residents, and I'd say making pretty bad lifestyle choices in their different situations. I think the prioritization, and I think a lot of that has to do with debt and how they manage their money. And I think there's a real challenge for I would say the elderly in our group to try to relate to that, and yet I don't see that necessarily happening.
Thanks, Dick. I think one of the things I learned from Bill Futrell, of the many things, was the integration of formal academic faculty with clinical faculty in private practice. People bring different things to the table, have different skill sets, and that blend is what optimizes education and experience. University of Wisconsin is very fortunate to have several key clinical faculty members, Jim Grotting, who lives in Birmingham, and Mark Constantian, who's at the microphone now, who lives in New Hampshire, who make yearly and frequent contributions to our residency program on-site and remotely. I think we need to be creative. There are a lot of smart people in this room. I think it's less important what your address is than what you want to give back. Mark.
Well, thank you for that, Mike. It's unexpected, but gracious of you, as always. I thought your presentation was wonderful. It's a topic we all need to think about. The thing that's the way I've begun to think about this over the years is that when surgeons or anybody, particularly in this case surgeons, are in distress in some way because of some unhappiness, they try to medicate that pain. And they can do it with alcohol or drugs or other ways. But an easy way to medicate pain for surgeons that's another kind of addiction is work. And who doesn't love the surgeon who's always available, who's always working, who's always willing to write another book chapter and take on another clinical responsibility? So it's positively reinforcing in the wrong way. That's something I had to come to terms with in the past. And I think there's a difference between working hard because you love what you do and working hard because unless you do, you feel like you don't have any self-worth. If you're working for self-worth, that's not right. If you're working because you love your work and you're happy to have this skill, then that's a different thing. And I think it's something each of us has to look at, recognize our motivation. I had to do that too, and it's in making that distinction, it helped me straighten out a lot of things and run my life better.
Thank you. So in the interest of time, I think we need to move forward with the academic scholar presentations, and I hope that we continue this conversation in the coffee break, tonight, tomorrow, next week, next month. I think we really need to address this organizationally because I think it's important to the future of our specialty. We have a lot of challenges. This is one that we should be able to remedy. And again, I appreciate your attendance Saturday morning, everybody being here, and I appreciate working together to solve this one challenge for us moving forward. Thank you.